Good afternoon, everyone. I'm from Singapore, and I serve as an emergency physician in my department. This is just a brief outline of what we did during the SARS episode. This is Singapore in perspective. It's a very small country, right at the tip of the Malay Peninsula. This is the island itself. It is an island country. It is the size of New York, and it has 4 million people staying in it. It's a tropical country, city, urban, green all the time, tropical greens all the time, a mixture of people, multiracial. 80% of us will be Chinese, and there'll be a mix of Indians and Malays. It is food paradise. This is our signature dish, chili crab. Yes. All right. Ministry of Health runs the entire healthcare system in Singapore. We have 6 hospitals, 2 tertiary care hospitals, the Singapore General Hospital, which is one of the oldest, the National University Hospital, which is where I work, and the Children's Hospital, 2 other smaller hospitals, and Tan Tock Seng Hospital. Now this is of note because it became our SARS hospital. We sacrificed this hospital for SARS. Emergency medicine started in 1948 as a casualty and outpatient, but in 1984 we developed, it was recognized as a medical specialty, and we have training programs and everything for it now. My university hospital is 20-year-old. It's 928 beds. It supports the clinical teachings for undergraduate medical students and postgraduate training, and it collaborates with our only university, our medical university, which is National University of Singapore. It is also the first hospital to be JCI accredited in Singapore. Now I'm going to take you through a tour of my department, how SARS affected its function, and how we developed along the way. 12th of March 2003, Ministry of Health officially alerted us about SARS, but there was no instructions. I was on night duty that night, and I tried looking to CDC website, to WHO website. There was no mention about how to prepare for it. So we went on back to basic principles, which was infection control, how to adapt the workflow of the department, and how to optimize our workforce. What is SARS? If you can remember, it's a respiratory infection, very simple symptoms, fever, headache, dry cough. The epicenter was in China and Hong Kong. It was a coronavirus that caused the problem. Incubation period was up to 10 days. And it spreads from person to person, especially when they're severely ill. The clinical diagnosis was the only thing we could bang on. No, there was no lab test whatsoever at that time. And there was no vaccine and there was no specific treatment. We saw 2 phases in the outbreak. Phase 1 in late February and March, it was caused by travel-related cases. Patient from Hong Kong landed in Singapore and started to spread. We saw another phase later in April. Unrecognized cases started slipping into the hospitals, and it started to spread amongst our healthcare workers. These are the 2 phases. First phase, where it was caused by the index case, and the second phase, which started to spread within the hospitals itself. A total of 238 patients was down with suspected SARS, and there were 33 mortality. Now, what basic principles we adopted? We wanted to isolate the patients. We wanted to cohort the febrile patients from the non-febrile patients. So we went back to very basic things. We used the field management term advanced triage point. All right. We developed the fever area. We changed the ventilation in the emergency room, and we increased our staffing. This was the advanced triage point. It's a field triage point where we started to screen for febrile patients. And slowly it evolved into this, what we call a screening station now. I think WHO adopted this. What happens here is that the patient will come to us and a temperature will be taken. While the temperature is being taken, they'll have to fill up a health declaration form, meaning questions like, where were you last visited? Were you in contact with any patients with fever? Do you have any relatives that have SARS? So these are the few questions that we asked them. And these questions kept evolving as SARS cases started to change and the location started to change. So these are the nurses helping the patients fill up the health declaration form. It's simple if you are dealing with 1 or 2 cases, but our emergency department sees about 300 patients a day. And along with these 300 patients, there will be another equal amount of, at least equal or more, visitors. And even the visitors have to be screened. So it was quite a task for all our nurses. And they have to put on this protective garment, the personal protective equipment. It's hot in Singapore. It's tropical, so it's like 80 or 90 degrees Fahrenheit all the time. And we had to work under such conditions. So this is probably the relative of this patient filling up the questionnaire. It takes about 5 minutes each. And there was a backlog of patients because of the sheer number and the number of questions we had to do. Now this is interesting. This is a thermal scanner. All right, because of the sheer numbers that we have experienced, we put up this thermal scanner in front of our department so that we could scan anybody that walks by. What will happen is it will light up red on the screen if you have a temperature. It can be preset and it will light up red on this screen. Now it says here, no radiation. What happens is the visitors and the patients started avoiding the scanners because they thought we were trying to zap them with some sterilizing rays or something like that. So we had to reassure the public that this is just for thermal scanning and we just want to detect whether you have fever. If the patient or the visitor lights up red in the screen, they will be asked to go to another screening station where a proper temperature will be taken. All right, so this is for quick screening. Now this is the emergency department on the left. This red area is the marked area for our fever facility, our fever area, where we cohort the febrile patients. So no patients with fever will enter into the department. This is the external view. This is a canopy above. It's actually our car porch. And we built this febrile area within the car porch itself so that it could last a bit longer. Now this was erected within a week. It took 2 days to plan, and it took about a week to sort of tighten everything up and make sure that the computers and stuff was working. What happened was we duplicated our entire fast track area outside into this tent. This is what it looks like. It's made out of cheapest stuff, whiteboard hoarding, white canvas material, anything we could salvage and get as quickly as possible so that we could accommodate the patients. All right. Chairs were laid out outside, free ventilation, and they were allocated chairs for febrile patients. Because of its whiteboard hoarding, we ended up calling it the White House. So this is what it looks like. Just simple board doors, all right, chairs laid out for them. This is interesting because we developed a toilet outside this tent, and this dark gray area is actually a mobile X-ray unit. Okay. Now the toilet was important because patients that required the restrooms should not enter into our emergency room. All right. We wanted to isolate them from the emergency room altogether, so we put this out here, and X-rays should be taken outside the emergency room. So we developed this mobile X-ray unit here. It's a lead line actually. This is another view of the fever facility. This is what it looks like inside. This is the screening station, which you saw earlier. This is my main emergency room, the fast track area. If patient comes here, tested to be febrile, they will be called to sit in the rows of seats right in front. And after they have answered the questionnaires and everything, the nurses will bring them into the fever facility. The green areas are for patients who can sit. The red areas are for patients who have to lie down. But they're all non-acute cases. These are for fast-track patients, all right? And this is the comm center where our doctors and our nurses work. So basically what happened is doctors and nurses are duplicated from the fast-track area. The area in which they sit is duplicated. The waste disposal is duplicated. The mobile X-ray unit is duplicated here, and the toilet is here. So there's no reason whatsoever for any febrile patient to come into the main emergency room. Now with all these patients, what do we do? Within the fever facility, shower curtains for easy maintenance, chairs for them to sit down. The rooms are 2 meters apart to prevent droplet infection. And there's some basic tables and chairs, tables for them to put their stuff in. Now you notice the sign here, it says ready. After every patient, the whole cubicle gets wiped, gets disinfected. And once it is ready, we'll put the ready sign and the next patient can come in. All right. This is the trolley area for the patient to lie in. Now with all the patients, what happens to the visitors? Potentially the visitors would have been in contact with the febrile patient, and potentially they would have contracted SARS if there was a SARS patient amongst all this. So we had to develop another area for the visitors, and this is the visitors tent. It is part of the fever facility, just 1 or 2 steps away. Again, it has its own toilet. It is air conditioned with amenities, drinks, biscuits, to keep the visitors happy, because we're actually segregating them from the normal population. Strategically placed plants so that they can hide behind from the prying eyes of the public. There's a lot of stigma at that time. When you were like febrile, people would try to avoid you. They'd be wondering why you're sitting there, you know. So there was a lot of stigma involved, and we had to put these plants, because sometimes they do not want to go into the tents. They would rather sit out in the open. So that was for the fast track area. It was easy to duplicate. We just copied whatever into that fever facility. What about the priority 1 and 2 cases? All right, that was difficult because we didn't have enough manpower. We didn't have enough resources to do that. So we changed the ventilation system and we boosted our manpower requirements. This is the priority 1 and 2 area. This is our resuscitation. This P1 area is the resuscitation area. This is our priority 2 area. The entire room was made negative pressure with special beds designated for febrile patients. These have HEPA filters installed above them. This is our resuscitation area. These are the vents which specially ventilate these designated febrile areas. This is still within the priority 1 area. Now this door is a electromagnetic door. It's moved and closed, and it completes the seal for the isolation of the patients within. It has to be closed to complete the isolation. This is the priority 2 area. You can see some of the vents here. I'll show you more clearly. These are some of the vents which are over the designated febrile areas. Now the other problem we had was the emergency department was right in front of the main road, and we were the thoroughfare for the entire, both for visitors and staff, to the entire hospital. So we had to lock down our emergency room to prevent people from freely moving in and out. So we had access card entry only, exit and entry only. So all the doors were sealed, everyone. Now this is our electronic recording system, our charting system. It's been 7 years since we adopted it. But what we're trying to do is to develop it, to enhance it, so that it will sort of become a surveillance system for us. So that cases, atypical pneumonias and stuff like that, if the numbers reach a certain point, it will sort of sound an alarm to our administration so that we know. Because with emergency rooms, the attendings sort of change shift, and this attending may have seen 5 atypical pneumonias, and the other attending could have seen 3 or 4, but they don't communicate. And we sort of miss like the early signs of an epidemic outbreak. So we're trying to enhance this system. Now this is one of my residents. All right, this is one of my residents here. I draw your attention to what she's wearing. This is standard issue from my hospital. It is waterproof, it's imported from UK. It is supposed to protect us. But during the SARS period, where we had to don our personal protection equipment, it became too hot. It was too hot. We had our N95, we had this on, we couldn't breathe, we were perspiring inside, we could collapse anytime. It was like heat stroke anytime. So we had to change this to t-shirts and sports pants, cooler, so that we could put on our protective equipment. The protective equipment was water resistant anyway. So we sort of threw this out and changed to t-shirts and sports pants. The other technical problem we had was because of the protective equipment and the added exhaust to create the negative pressure, our air conditioning system couldn't cope. And it was like a furnace inside our emergency room. So we had to install another 4 units of horsepower blowers to cool the place down again. So these were the little things that we had to, change as the SARS event developed. This is the personal protective equipment, caps, goggles, N95, noise certified. This is a water-resistant gown, gloves, and shoe covers if necessary. Now this is the powered air purifying respirator. This took a long time. We chose this. This is a striker system. It is all enclosed within. This is a hood that goes on top, and this filter, the blue filter, and a cap goes over it. So it's all self-contained within this little helmet up here. Now before this, we had this elephant trunk, and the filter was at the back. All right. We had problems with that because we have a rather fat consultant in our department that when he bends down to intubate, the thing snaps and everything falls on the floor and the whole system is compromised. So we had to think, and it was very clumsy, that tubing had to be, caught on something behind and stuff like that. So we had to go back to the market and started choosing which air purifier system was the best. And we came out with this Striker system, which we found very convenient, very easy to use. All it has is this helmet, the fan is within the helmet, and you just place this filter cap over it. And you put on this personal protective equipment. Okay. Now, all medical intubations will require us to put on this equipment. What I mean by medical is any person that is not involved in trauma. Okay, anybody that has respiratory arrest, respiratory compromise, and was not involved in trauma, the person that's going to intubate and the airway nurse will have to put on the equipment. All right. So unless a patient has fallen from height, head injury, requiring ventilation, we'll put on a simple visor. All right. But other than that, we will require all our personnel that's intubating or managing the airway to put on this equipment. And it still goes on now, till now. Now, because we didn't have any tests to test SARS, all right, we had to find tests which can exclude other diseases that can mimic SARS. So we have pro-BNP for testing of cardiac congestive heart failure, because SARS presented with breathlessness, so does congestive heart failure. So we had to distinguish the patients. Dengue, I don't know if you know about dengue fever. It's rampant in Southeast Asia, particularly in Singapore. We just had a big epidemic now. We had to test patients, febrile patients. We had to do IgM on them to exclude SARS or proof that it is dengue fever. And everybody with fever had a CBC count. Now we have a PCR kits and stuff like that. So hopefully it will be easier this time around. Now, this is interesting. This is a spacer for treatment of asthma. I think in the United States, similar to Singapore, we treat our asthmatics with nebulizers. All right. This is the best way to distribute the SARS virus. Okay. All right. So we had to change our management for asthmatic patients. Now, you thought it would be easy, but we had to convince our own staff that using an inhaler, it works as best as a nebulizer. And after that, we had to convince our patients that this is good for you. Take a few more puffs, it will work. But they'll say, where is the oxygen? Where is the mist? Where is that sound which I hear usually? What are you doing? They were not convinced at all. So it was an uphill battle. It was like we had to convince our staff, who has been so used to plugging the oxygen, let the mist come out and stuff like that. So we had to manage all that. We had to convince our own staff. We had to convince our patient. And we had to bring out evidence-based medicine. In UK, the inhaler is first line. So we had to prove to our own staff that this works just as well. And thereafter, our staff will convince the patient, hopefully, that it works just as well. It was a terrible battle. It's terrible. And we had to issue this because not everybody is trained on the inhaler. So this was the only way. We had to distribute it free. We couldn't charge the patient at all because we were changing the way we're treating asthma. So this is how SARS affected our management of other diseases. And all this, we had to pay a price for it. By this time, after building that febrile unit and stuff like that, we were about like 2 to 3 million to deficit. But we had a very strong word from our government, our ministry, do what you can, we will absorb everything. So that was the comforting part. So we had to do what we could. Because of the duplication of the triage and the fast track area, additional manpower, additional equipment, the number of N95s we used, the number of the gowns we used, multiplied like 10-folds or something like that. We had to change. In between patients, we had to change. So the cost just went escalating. Now this is the key to infection control. It's the most important, hand washing and donning of the PPE. Now, what our infection control nurse did was to institute a testing of hand washing for everyone. All right, this is the instructor or the tester, and this is the testee. The 7 steps of hand washing. All right, everybody has to do it, even the heads of department. I know my boss failed the first time, but he picked it up quickly. We had to pick it up quickly. And this was done every 2 weeks initially to train everybody and to put it, to sort of become a habit. And this one, you look at the testee, so sad. This is how to put on the PPE, which sequence it goes. We have instructional videos to teach our staff how to put on a PPE, all right? And it was a terrible time for our infection control nurse. They had to go around, not only in the emergency room, they had to go up to the wards, to everywhere. Everybody that was in contact with a patient or potentially a febrile patient had to be taught what to do. And you'll be certified that you have cleared the test. All right. Without that, you can't come to work. Now, environmental services. This is a new term I learned here. They are actually cleaners in my hospital. Oh. So now this is important. We had to teach them which is biohazard, which is not. All right. The biohazards have to take a particular route to where it is disposed. They do not walk all over the hospital. So it's a pre-planned route for them to move, so that they'll take this particular elevator. After that, somebody will come and wipe the elevator. All right, it'll go down to the basement, go down to the furnace, and it'll be disposed of. All right, so it has to be a planned route so that we don't contaminate the rest of the hospital. So all this has to be taken care of, and it has to be taught out before anything happens. Who knows about RFID? Basically, it's a wireless system. It's a device that allows us to read information from a tag without any physical contact. All right? It's been around since 1970s, and we used it during SARS. Anybody that entered into our emergency department had one around their neck. What happens is each tag has a reference, our identity and our name, our contact number will be referenced to that tag. And no person without the tag will be allowed into the emergency room. This is the tag in question, all right? This is one of my staff, and without this, you are not allowed into the emergency room. Do you know Harry Potter's Marauder's map? It is akin to that. So basically what will happen is we are able to track every single person, every single visitor that comes into the emergency room. What will happen is if there's a SARS suspect, all right, contact tracing will be done. And anybody within a 2-meter radius will be identified and quarantined. So that's how we use technology to help us. The standing joke then was our boss would know what time you come to work, how long you've spent in the toilet, and what time you left. Okay? All right, so the location of everyone was stored in the computer. And it helps in the contact tracing. It makes it efficient and makes it fast. This is the tag, this is the brain, and it costs quite a bit to wire up our entire emergency. This was only for the emergency room because of the high traffic flow and the number of visitors that comes in. So we were able to contact trace and track our patients and visitors in that manner, and the staff for that matter. Surveillance was the other very important thing we did. As you can remember, the second phase was amongst our healthcare workers. A lot of it was amongst our healthcare workers. And by conducting surveillance on our own healthcare workers, we were able to identify patients, or rather our own healthcare workers that were potential SARS patients too, because they were in contact with other patients. And they had to take temperatures morning when they come into work and when they leave for off work. All right, so 2 temperature takings each time. And if they're febrile, they're not to report to work, but instead report to the screening station and be seen by a doctor. Okay? This was strictly enforced for all staff. One of my colleagues, female colleagues, found out she was pregnant because of the temperature spike before the urine pregnancy test was positive. So that's how strict we were. We plotted, we checked everyone, and we were monitoring how the medical leave, the medical certificates, which when they're on leave, why are they on medical leave? Is it febrile? Is it a cough? So we track so that we can identify fever clusters within our own healthcare professionals, and that's how we stopped the spread within the hospital. Now, we had draconian measures during that period. We had very strict quarantine rules. Only one visitor allowed for patients within the emergency room. No visitors for febrile patients at all. All right. So we had to maintain links for these people. It is quite terrible to sort of like tell your mom is quite sick, but you cannot visit her. You know, it's horrible. So what we did was we developed this video conferencing unit here. This is a visitor's lounge with a video conferencing unit. This is what it looks like. So they are able to connect with the patients. So the visitors can actually talk to the patients, or for that matter, to the attending physician if necessary, so that they can update themselves on how their relatives are doing and stuff like that. So this worked pretty well for them. Now, we adopted the Higgs system. I think you guys should know what it is. What happened during that period was we didn't adopt it full scale. We changed it, we improvised it. It gave us the command, it gave us the control, and it allowed us to communicate within each other. So it was a good system. But we had to change it because we needed help from an ID physician to advise our commander. And this sort of slot in between the finance and somehow it was modified. So apart from that 5 cells, the main 5 cells, we had an ID physician that became here somewhere between the safety officer, the liaison officer, and the information officer. So we adopted the Higgs system, but we modified it to suit our needs. I think that was how it was planned. We set up our ops center. This is where we do our contact tracing for the hospital. We have a bigger contact tracing unit for the nation, where all the hospitals will feed the information to that unit. This is my CEO with the ID physician. We had every morning, 7:30, without fail, they had conferences to develop plans for that day. And every day the plans changed. We had a disaster plan, but we changed it completely. And what we found out during that SARS period was communication was the key to everything. It had to be prompt, it had to be effective, and it had to be coordinated. All right. Visible leadership was important. I think New York during the 9/11 had Giuliani. He was the epitome of communication. All right. So we had our CEO to address everybody, reassure everybody that we are in control of the situation. It needs to be a centralized communication, all right, one voice. And usually we went through our corporate communication. Now this is my HR manager. He worked 16-hour shifts consecutively for almost a week. And we couldn't put him up anymore in the podium and address the staff. So we had to watch ourselves. We had to watch each other, watch for each other, because fatigue will set in after a while. And we had to change him. It has to be a single voice, all right? It has to be consumer-friendly language. SARS suspect, we had to define what a SARS suspect means, what a confirmed SARS means. We had to address it to the staff so that they know what they're dealing with. And when they talk to the public, they know what they're saying, all right? And we used every single means, be it from website, bulletin, emails. We even had a bulletin board put up in our emergency room. It's down to that basic, so that everybody that walks by our emergency room will update themselves on this, whatever our Ministry of Health has dictated on that day. Because each day, the criteria for fever changes. Each day, the admission to the isolation ward changes. Because as SARS evolved, we had to change. So information was very important, and communication was very important. Risk communication to our staff members, they need to know that they are safe. We need to tell the family members that their children, their wives that are working in the department are safe. So we need to educate them. We need to show them that we are taking measures to protect them. Till now, nobody has proven scientifically that the N95 actually can prevent the infection. But by giving them the N95, by giving them the personal protective equipment, by showing support from the hospital, all right, we are allowing our staff to come back and work. And they feel safe, their family feels safe, so that they don't have to worry about their own family members. There was a lot of questions. Will I bring the disease back to my family? Some of them self-isolated. I know my colleagues self-isolated themselves from their family. They rented a place nearby and they stayed For that whole 3 months, they stayed within that so that they can isolate themselves from the family. So that was how we coped with SARS, and it was quite a trying period. We have to monitor the information that's going on outside. There were a lot of rumors, strange things were happening. People were like shunning this area, they were shunning this hospital. The property price dropped when a SARS case was found in that area. So that's how fast they are reacting to the whole thing. And there were rumors going on like the neighbor has SARS, that sort of thing. So we had to correct all this. There are new imports of SARS. So we had to monitor. We set up an inquiry center for our patients, for our relatives to call in. And we will correct information. Misinformation is the worst thing that can happen. And it is a terrible threat because it will start to spread, and it spreads like wildfire. And you can't change that. And we made use of media. We used media to educate our staff. We used media to educate the public. So that was the important move we did. There was a lot of psychological aspects to SARS. It became a fashion statement to wear masks. All right, this is definitely the wrong way to wear a mask. All right, it has become part of our life for that 4 months. Everybody that was walking around had either a correct way of wearing the mask or wrong way of wearing the mask, but they were just wearing it. Okay, it had a lot of implications. My staff members couldn't hail a cab because they were in uniform. That's how bad it is. They see a person, a nurse in uniform, the cab driver will drive by. The buses refuse to stop right in front of our hospital because of that stigma. So our government did a lot to change the people's attitude towards that. People that rented houses were evicted. They were chased out of their houses. That's how bad it became. It was a stigma to be associated, to be a healthcare worker. That was how bad it was. So we had to change the public's attitude to the whole thing. And they had social aspects. Can you imagine going to a concert with masks? All right, going sightseeing with mask on, wedding with a mask on. So this was really changing our everyday life. And of course, the prices of masks went up sky high during that period. Now, what did we learn from this whole thing? All right, I think first thing is when disaster strikes, we need to allow the ground staff to work within their little means, their little department first, to establish certain devices so that they can prevent the development of the disaster. All right, because we didn't have any official instructions during that first period. My boss was not around. He was vacationing in Cebu or somewhere. And we had to evolve on our own. And I think that little bit of flexibility was useful. All right. Early detection of the disease, early isolation was important. All right. And early containment. All right. Careful record tracing, contact tracing, and careful record keeping was also very important. It allows us to contact trace and quarantine these patients very, very quickly. And infectious disease, when they do strike, ultimately it will become a nosocomial infection. It will spread within the hospitals, and the healthcare workers would be the ones at risk. So we have to bear this in mind. Infection control, the key to preventing a pandemic, all right? Personal protective equipment, hand washing, very important. Rehearse and test and rehearse again. The Higgs system, useful, but it needs to change. It needs to be improvised. And communication, very important, both for your own staff and the public. Surveillance to prevent spread within the hospital. Alternative disease markers to exclude the disease. You have to change your management, as we did for asthmatics patient. Surge capacity planning, not just the facility. We need to search for finance, and we need to search for manpower too. All right. New technology, we need to embrace it. Try to help us as we use the RFID. And a business continuity plan for the hospital. In Canada, I think Canada was struck by SARS too. Out of the 4 hospitals that had SARS patient, 3 of them are running at 60% capacity, even until now. Reason? The stigma of SARS still stays. Children knows that's a dirty hospital. I don't want to go there. So in Singapore, what we did was we sacrificed 1 hospital, and we had a big publicity campaign campaign after the SARS episode. We cleaned up the hospital and it came back to normal again. So that was what we did. This is what I call the new normal for the emergency department. Fever screening is a permanent feature. Till now, we screen for fever and we cohort them separately into our fever unit. Personal protective equipment for all emergency room staff when they're attending to febrile patients. Enforce strict infection control. Surveillance for our own staff. Permanent fever facility. Constant alert for emergent infections. And integration of an infectious disease plan to the hospital workflow. This is our permanent fever unit that we're building. So we receive funds from the government to build this unit. It has 18 rooms and it will be a permanent structure in our hospital to accommodate febrile patients. All right. Now, what did this was all in the emergency room. What did the hospital do? How did the hospital respond? We had parking, 2 levels of parking. In order to isolate staff from the public, we restricted access to one parking from the public. So the staff parked at one level, the public parked at one level. And within, in the entrances and exits of the parking area, we set up screening stations. We had screening stations all over the entrances and exits of the hospital. So this is car park 1, which is for the public, and A1 for the staff. So before you actually enter the hospital, your temperature will be taken, and if you have a fever, you'll be directed to another screening station, and you'll be seen by a doctor. We took temperature taking to the hilt. We had problems defining temperature. What is a febrile patient? Ultimately, for screening purposes, we took the temperature of 37.5. All right? And if you have a temperature at a screening station for 37.5, you'll be directed to a screening area where oral temperature will be taken. Not the ear thermometer, because we found that there was a lot of variation. When the patient is elderly, when the technique that you use is wrong, that there was a lot of variation. So the ear probe was only used at the preliminary screening stations at the entrances. When it comes to our screening station in the emergency room, a 1-minute oral temperature is what we take. And strange things, we found that trauma patients had a temperature when they arrive at the ER. A 30-minute ride in the ambulance will cause the patient to have fever too. So we had to wait, let them rest, and retake the temperature again. So it was very interesting. The way we defined temperature was very funny. It was like it changed for the first few days, and ultimately we settled on 37.5 for screening and 38 for real febrile patients within the emergency room. So there was a lot of debate too. So these are various screening stations all over the hospital. This is to the clinics. So any visitor or patient coming to the clinics, the specialist clinics, will be screened. This is another entrance. This is the car park dispenser, the ticket dispenser, where they pay their car park fees. So before they pay, they will have to be screened again. This is outside our main lobby. All visitors that come by and wanting to enter into the university hospital will have to be screened. This is what it looks like. There were screening stations everywhere, and there were queues everywhere because of the sheer number of visitors that come by. This is our south entrance. Some patients do not want to stay in an air-conditioned room for obvious reasons. They don't want to be associated with a febrile patient. So we had to put chairs outside in the open so that they can sit out here. And we had to put fans all over the place to cool them because it was uncomfortable in our weather to sit outside. And they would come in. Again, there will be chairs, and they'll go by the screening stations again. So these are for visitors mainly. Now, we have special isolation wards for febrile patients. They are negative pressure. The whole ward is designated for febrile patients. They are negative pressure. They are isolation rooms. Each individual patient will have its own room. And the nursing staff will be in full protective garb. And this is one of the handover sessions during the nursing rounds. And they will be in this area for that whole period. We had to show the nurses that the whole place was negative pressure. Physical signs, as in they were to put tapes or feelers that show that the pressure is being generated, so that to give them a reassurance that this is a safe place to work. Otherwise, they will not come to work. So we had to do our part. The hospital had to do their part to provide them with all this so-called reassurance. We had labs. We had to boost our lab capacity and capability. The cleaning crew, you'll never know how many times we clean our elevators and our floors. The security officers, we had to enforce the lines, make sure everybody didn't quarrel with each other, and we had to enforce many more security measures so that the patients and the visitors don't wander all over the place. We have people ushers so that they know where to go, and we have a contact tracing crew. So all these were added costs to the hospital. And as a nation, what did we do? The first thing we did was we set up a separate line for febrile patients. All patients with fever, they call this number instead of the 991. So we dedicated a fleet of ambulances to pick up febrile patients alone. So this was how we sort of segregated the febrile patients from the non-febrile patients. And we sacrificed one hospital. This is the Tan Tock Seng Hospital. The entire hospital was closed, no electives. The surgeons were very poor that 4 months. The entire hospital was changed to sort of like an ICU unit. The entire hospital could be converted into ICU unit. So it's almost 1,000 beds within this hospital. And all SARS suspects will be brought to this hospital and kept in the hospital for 10 days. Because in the initial part of the SARS period, we didn't have a test, or rather it took a few days before the test could be conducted on these patients. And most of the time we relied on the incubation period of the disease. And we quarantined or we isolated them for 10 days. After 10 days, if you don't develop SARS, you are cleared of the disease. So a lot of patients were housed in this hospital. As a nation, our government did a lot of education. We taught them how the bug came to in Singapore, all right, who it affected. This was publicized in our Straits Times, our newspaper, and it told the public what happened exactly. Who are the people involved, all right? Who are the ones that are contagious? Who are the ones that caught the bug? How it became a chain effect, all right? How were they related? How were the patients related? Which area was affected? We taught them quarantine measures, why there should be no visitors in the hospitals, because it's where we catch the germs, all right? This was social distancing measures. Visitors with contact with SARS patients were given quarantine orders for 10 days. And if you violate that quarantine order, you will have a tag system, a camera installed in your house, so that the neighborhood police will be able to monitor your movements. All right? The quarantine order requires you to call back to the police station, I think every other day or something like that. If either you miss or you violate the quarantine order, a camera will be installed in your house. And if you still violate that, I think there's a location tag for criminals, and that will be placed on you. And if you still do that, if you still violate that, you'll be put into the prison. So that's how strict our government was. Now, there was a lot of ethical issue. It was personal rights against public safety. And this didn't happen in Singapore. This lady was quarantined for 10 days, and she's attempting suicide. This happened in Taiwan. All right, 10 days. Can you imagine staying indoors for 10 days with nobody around? So it was a difficult moment for everybody, and we knew it was difficult for everyone. And the staff that helped the people, why should they help? Why should they stay to help? So there was a lot of ethical issues involved. They could have left and take care of their own family. They need not turn up for work. So these issues were very rampant during that period. Now, how did all this affect our preparedness now? Avian flu is an influenza virus. All right, it occurs naturally in wild birds. They shed it in their saliva, their nasal secretions, and in their feces. All right. It affects domestic poultry. The wild birds do not get affected by the avian influenza, but it kills poultry. That's what happened in 1997 in Hong Kong, where they had an outbreak of avian flu. There was one possible case of human-to-human transfer, in Thailand. But till now, I think nobody has proven another case yet. So what's happening? So the question is, how did the virus affect us? How did it transmit? Now, from the virus from the birds in the wild can come either directly to humans, all right, or go through other animals, particularly the pigs, all right, and come to the humans, all right. We would like to think that we're quite different from birds, so this route is a little bit difficult. But the strange thing is the pigs can accept both humans and bird viruses. And this seems to be a petri dish for all the viruses. Okay, so this is the most likely route that it can come. All right, and once the virus comes to the human, what makes them become infective to the other humans? We hypothesize that if you have a co-infection of a human influenza A virus and an avian flu virus, the genetic material will mix within that patient. After mixing, they will acquire the properties to transmit between humans. That's why we are so paranoid about avian flu outbreaks in poultry in the whole of Southeast Asia. Because the more outbreaks there are, the chances of transmitting it to a human is higher, and for it to have a co-infection in the same person, it's higher. And that's the other reason why we are also advocating vaccination, flu vaccination. Hopefully, co-infection doesn't occur to allow genetic mixing. The other problem is, what about HIV in patients? It has been shown that influenza viruses shed much longer during the infection phase, the infective phase in HIV patients. So these are areas where they can actually mix with the avian flu. So these patients are also susceptible to creating this human avian flu viruses. This is the spread. It's total of 100. This number keeps changing every day. I have to update the slide every day. 132. The new outbreaks are in China. There are rumors that, again, they're not revealing all the numbers. All right. I think Vietnam and Thailand is doing a great job. They're very open. All right. But Indonesia, it's quite scary because the whole population in Jakarta seems to have antibodies positive. So it's rampant in Indonesia. So we're not sure what that means. This is the flight path of all the migratory birds. Basically, this slide shows the birds are everywhere. So it has come down to Turkey. The next stop would be in Africa. And I think some of it is already in the northern United States. This is the death toll. Mortality rate is 50%. The two in China, this is the most recent. So how is avian flu related to the pandemic flu we had? To study the avian flu and how its mechanisms and how it will affect us, we looked back in history. The pandemic flu that occurred in 1918. It was dubbed the Spanish flu because of the World War. All the other countries had a media blackout except Spain. So Spain was the first one that announced the flu pandemic. So it was dubbed the Spanish flu, and it killed millions of people. This is Kenneth Crotty. He was 11 years old when the flu affected. It started actually in United States, in this place called Camp Futon. It was a military camp. And it was the Americans that brought it to the British when they invaded Britain. So that's how it went to Europe. And after the Spanish flu, in 1957, it was the Asian flu, less deadly. And in 68 and 69, there was a Hong Kong flu. Now, there was a difference between all these flu pandemics. This one was created by an antigenic shift. It was a swine flu that changed, and it became transmissible between humans. It was an antigenic shift that caused this. The other two flus, which were less deadly, were actually from antigenic drift, and they sort of modified their genetic component so that it became human transmissible. So it was a slightly different flu that affected the last two. What is the influenza virus? It is the orthomyxo virus. There are A, B, and C types. A is the common one, which can both infect human, swine, horses, and birds. There are surface antigens, the H antigen and the N antigen. The different antigens determine what they are and how infective they are. And again, it is the antigenic shift that causes the pandemic flu. So are we ready for this avian flu attack? Now, King's College did a computer simulation in Thailand. This is the outbreak. The first 30 days, it becomes like that. All right. And in 90 days, the outbreak becomes an epidemic. All right. By calculation, we only have about 3 weeks, less than a month, to institute whatever measures we have before it becomes an epidemic and later spread into a pandemic. And these are the numbers that you're dealing with. This was done in King's College by Professor Ferguson, and subsequent simulations, I think, also confirms the time frame which we're dealing with. Now, what is the fear? In Holland in 2003, we had an avian flu outbreak in poultry, not humans, in poultry. And it took the Dutch army to control it. And even then, it spread to the Belgium and into Germany. So what happens if it does affect humans? It will take much more efforts. And what is the problem? In China, the birds roam around freely amongst the population. In Vietnam, they're sold in open markets. In Indonesia, they're transported in this manner, and they are kept as pets. All right? So very close proximity with the livestock. And the other problem is, it is their livelihood. Very strange for people who know that the bird is infected and they would still keep the birds. Why? Because it is cash for them. Every bird they cull, all right, is loss of income. And the problem is, this problem is within the poorer places in Asia. And by culling the birds, you're actually depriving the farmers and the people that breed the birds of their livelihood. And they would rather you disinfect them, they would rather you vaccinate them, they would rather you do everything else, than to cull the birds. And it is good that WHO and the world is looking into compensating for this. So what is the solution? This is in China. They send people and the police to enforce culling, all right, or mass vaccination. That's the latest proposed by China. 14 billion chickens to be vaccinated. So there's a lot of doubt to the quality of the vaccination, how is it going to be done. So there's a lot of debate over how China is going to do it. And recently it's been spreading around the whole of China. The avian flu outbreaks are occurring everywhere. Now there's a very fundamental difference. All that I've said today was based on SARS, but SARS is not influenza. All right? SARS was not infectious before the symptoms. We were very fortunate. Influenza is 1 to 2 days. Those who have children, I'm sure you know. 1 to 2 days before it actually shows symptoms, they are already transmitting it. And SARS spreads in hospital. Influenza spreads outside the hospital. Even now, we can transmit influenza. Isolation, because of the nature of the symptoms and how it spreads, isolation and quarantine was useful for SARS. All right, but influenza may or may not be useful. By the time we actually institute quarantine measures, it may be too late. And the other problem with avian flu is it affects children. SARS did not have a single child mortality. It never affected children. Our whole children's emergency was empty. They didn't dare to come to the hospital because we didn't have any problems with children for SARS. But now, for avian flu, majority of the mortality is actually children. This is a breakdown of the ages in this article in WHO website assessing the pandemic threat. You can see almost 40% of them are less than 10 years old. So what are the defenses we have? We still do not have a proper diagnostic kit. There are antivirals, but we need millions of them to be effective, to institute effective control. We need an effective delivery method. Very difficult. In Singapore, we're trying to work on that. So for a very small country, we're still trying to iron out a lot of things, how to deliver this medication to the public and to the healthcare workers. You need a population to cooperate with any social distancing measures. Vaccination, they are up and coming, but none really available yet. And whether it will be useful during the avian flu pandemic, we're not sure. International cooperation and surveillance. This is the only thing we can bang on. This is really scraping the barrel. We're monitoring all the avian flu outbreaks. We're monitoring all our ports and our airports to prevent it from coming into the country. We have neuraminidase inhibitor, our only defense apparently. We need to have stockpiles of it. Only 50 countries have a pandemic plan, very few in Asia. And Tamiflu and Relenza has problems on its own. I think it's still not FDA approved for prophylaxis under 13 years of age. Not approved for treatment of children less than a year old. Relenza is not approved for prophylaxis at all. It's only for treatment. And only approved for treatment for 6 years old and above. So if you look at the numbers, I mean the age groups here, you're missing the critical age group which avian flu seems to affect most. All right. So how to treat the patients, how to provide prophylaxis for less than 13 years old, all this have not been ironed out yet. And the suspension for children has a shelf life of only 1 year, not 6 years as compared to the pills. So how much do we keep for the suspension? We have ring vaccination strategies. This was derived from the smallpox. That's how we eradicated smallpox. And this is part of our Singapore pandemic flu plan. But a lot of questions. Influenza stats from the previous influenza infections. 3 to 4 year old crowds the emergency room 30 days before the elderly comes in with influenza. And the current flu vaccination strategies, they target less than 2 years old and the elderly. So what about the 3 to 4 years old? So these are the ones that will start spreading even before the pandemic actually arrives. So we're actually missing that 3 to 4 year old group. So in fact, the 3 to 4 years old should be vaccinated too, because they will be the ones spreading the viruses. This is supplemental strategies. If it doesn't work, if this ring strategy doesn't work, we need mass vaccination. When there's no decline in the number of new cases after 2 generations, when there's no decline after 30% of the vaccines have been used up, it is not a first-line strategy. It is, again, scraping the bottom of the barrel. Now, United States did see an epidemic, and this was, I think, in 1916. I think stretched all the way to the 1950s and 1960s, where polio was an epidemic. This was in New York, I think. And United States actually quarantined people during that period, and apparently it was effective. Children under 16 were not allowed into a town because of that polio epidemic. And you had publicity. Here you see Elvis Presley being vaccinated for polio. So again, it was the same strategy we used in SARS. March of Dimes, I don't know if you can remember this. It was how United States actually controlled the polio epidemic. This was very interesting. This was how the parents visited the family, their children. I think we can replace this with video conferencing now. So Singapore has a pandemic plan. Its Ministry of Health has alert levels. All right, there are some key activities which I'll explain. This is the background which I've gone through. So large droplet, that's what we assume. Large droplet, okay, contact, possibly airborne. Infectious period is about 1 day before the onset of symptoms. Virus shedding 5 days after the symptoms. 3 weeks in young kids. So can you imagine quarantine young kids? And mortality. We experience 14.8 deaths per 100,000 for the usual flu season. So for avian flu, we are anticipating 60% mortality. This is how we are going to define a pandemic. 38 degrees for fever, non-productive cough, either an epilink, that means you have a contact with a person that was affected by avian flu, positive, a rapid test kit if we can develop one by then, more than 60 years old with no fever, all right, and a confirmed case, a lab confirmed case. We are already educating our children about taking temperature. We are watching our ports of call and our airports very carefully. I think Hong Kong has already instituted fever screening at their airports since the November 17th, I think. And there are a few assumptions which Singapore will take. Outbreak lasts for 6 weeks, attack rate of 25%, peaks in the second week, it means the second phase, 7 days to quarantine the patient, 15% of the flu patient will require ICU, 50% of the patients will die after 5 days in ICU. Recovered ICU patients will need to stay in the hospital for 10 more days before transferring to the general ward for 7 days. And 50% of the ICU cases will require ventilators. Now, in numbers, what does that mean? The nation, we have 550,000 patients. All right. Inpatient, we have 11,000. Peak in the second week. And we're assuming 825 patients in a general ward, 130 of them in the ICU requiring ventilation. So we have to cough out 130 ventilators and surge during that period. So again, it's easier for us because we have gone through SARS. We will go through, when the pandemic do strike, we'll again sacrifice the same hospital, all right, and all the patients will be put in that hospital. These are the various definitions, the alert levels. Green, yellow, orange, red, and black. That's when the spread is so rampant that there's no point quarantining anybody anymore. And Ministry of Health will again conduct surveillance, case management, the antiviral distribution, vaccinations, and communications with the public, basically public education. So these are the various alert levels and what the hospital would do. Isolation procedures for green level. So it's very simple for us. You look, surveillance, post-SARS measures. So that's what we'll do. And subcomponents of the plans. So staff listing and updating. All the staff that is working with febrile patients will be updated. The antivirals, the plans to deliver the drugs, PPE for all our staff attending to febrile patients, contact tracing at a national level, and visitor management, which was what we did at our hospital. This is the end of the presentation. Okay, if there's any questions?
First of all, let me thank you on behalf of the staff for coming to speak to us. Very good presentation, and having been there and been through that, you speak from a point of knowledge rather than just theoretical questions. Yes. I visited your country once. Mm-hmm. You're known for having an educated society, a good infrastructure, and a lot of a citizenry that is oriented toward compliance, following directions.
Yes.
We don't necessarily have that in all of the places that we deal with as a military, either infrastructure or compliance. And here in the U.S., some of us were surprised that some of the behavior after Katrina and folks not being able to organize themselves to follow directions. So your plan for your country in the event of an avian flu pandemic is wonderful. Do you have thoughts about what parts of that would be exportable to a society with more travel that was much larger, many more borders and ports of entry and that sort of thing?
Yeah. Well, Singapore is a very small country, and we have a very strict Ministry of Health, which is the voice for the whole government. All right. What I emphasized on was public education. I think by educating the public early, before all this chaos starts, all right, understanding avian flu, simple measures to avoid getting infection, the fear of getting an infection, the importance of getting the infection but not dying is not a death sentence. These public education messages should be out early so that the public will understand what I have to do when a pandemic strikes. What does the government expect me to do as a nation, to respond to this pandemic flu? A lot of what happened in Singapore was in a state of evolution. As the disease progressed, the public education was ongoing all the time. And we found that it helped because it didn't cause panic. The public understood why they had to be quarantined. All right. Of course, there'll be some one or two rogue ones which will refuse, But we had to teach the public that what happens if you do violate that quarantine order. And it was publicized in the newspapers and everything. So, yes, Katrina was a natural disaster, a scale which no country has ever seen. So, yes, maybe United States was caught a little bit unawares, but I think we have learned from it. And hopefully we can apply what we've learned in Katrina and hopefully prepare for the pandemic. And I have to emphasize public education, the public knowledge, the public view of this pandemic threat must be brought very, very early before the disaster actually affects them. And they must know what to do. Like the videos, little video script I showed, my public, or rather the Singaporeans, knew exactly 37.5, how to take the temperature, where to go for help. I think that will cause them to be a little bit more less panicky, and they know what to do. So I think that's the key component to this whole disaster response to SARS, which Singapore did. Yeah.
Other questions? Yes, sir, Admiral Welfare.
Yes, in terms of, in contrasting SARS versus the avian flu,
yes.
the quarantine and shielding or sequestering may not be as effective as it was for SARS, but how much do you discount that as a mitigation strategy? Would you attempt to isolate, though?
We will still isolate. We will still attempt to contact trace, we will still attempt to isolate. It may not be as effective as what happened in SARS, but it will still buy us maybe about 2 to 3 days for the antivirals to be distributed. And that 48 hours to 72 hours is very important to allow us to vaccinate, to allow us to distribute antivirals. Unfortunately, I think till now, nobody has come up with any proof that quarantine, isolation, in fact, even the vaccination, ring vaccination, has it ever worked for influenza? Nobody can say yes to that. So it is a lot of trial and error, which we found in SARS too. It was trial and error, improvisation. We had problems. The reason why there was a second spike in the infection within the healthcare workers was because SARS presented atypically suddenly. There was no fever. We admitted the patient as cardiac failure. So that patient slipped through whatever net we put up, it slipped through and it started infecting within the hospitals. So till that pandemic comes, till we are in it, we cannot actually say this will work, this will not work. But it is good that the surveillance, I think this is the only thing we have to rely on. Knowing where the avian flu is affecting, preventing the co-infection, preventing the virus from jumping into a human transmissible disease. I think that's the only way we can do that. And good thing is, internationally, we're putting a lot of efforts into it. Vaccine production, vaccine development, and preventing this transmission. So that's about as much as we can do.
Separate question. You have your color-coding alert
Yes.
system, and WHO has a similar one. You find the WHO,
WHO, yes.
Yeah, they have their
Yes.
6 phases.
Correct.
Does it correlate nicely with yours, or
It is more or less. Singapore developed our pandemic plan based on the WHO recommendations, but we sort of tailor it to our experience with SARS. So you'll find that the numbers and stuff like that are peculiar to Singapore. That's how that's the assumptions. We'll assume that these numbers and how we respond, how we search our hospitals, and which hospital to search to are based on our experience with SARS. So it is actually based on the WHO recommendation. So it's very, very similar. Yes.
Was there any data captured on, obviously a percent of the population avoided contracting the flu, and I wonder, every person's got a different immunity,
Yes.
built-in immunity. Was there any tracing done on what people did that caused them not to contract the flu? What were the preventive things they did?
Very good question. Now, SARS was a chaotic period, and in fact, a lot of studies could have come out from that period, but we were so busy trying to cope with the overload in the emergency rooms and in the hospitals that we didn't have the opportunity to conduct any proper studies. But what did happen was any patient that was admitted into the hospital, into our SARS hospital, they had blood tests and everything done on them. It was what we call a sero-survey for this population, this infectious population. And there is some data. Unfortunately, I don't have it with me at the moment. If you go through our website, in our communicable disease website, there will be some literature on it. There is some published literature on how what percentage of them were antibody positive but didn't have symptoms. It was very unusual because some of my nurses had antibodies positive, but they never manifested the symptoms at all. So it's something akin to like hepatitis C infection. You know, some people are carriers, but they're not. They don't manifest the disease. There is data, but unfortunately, I can't tell you now. Yeah. Yes.
So regarding the stockpiling of your antivirals, what process have you used to determine what is a sufficient number to keep?
We are targeting. We have what we call a preferential distribution. So the people working in essential services will get the medication first. That's a big deal too, because the public has to understand why. So essential services are, we have to keep the electricity running. Our sewage system has to continue. Hospital staff has to continue. All right. The police, the law enforcement have to continue. So these are essential services where they will have preferential distribution. Okay. Now, as to the numbers, I'm not sure how they derive exactly, but I think we are targeting about 30% of our current population for this year. That's the number of the load that we are giving. And by next year, I think we'll hit 100% of the population. All right. But there are a lot of questions about whether antivirals do work. So being Singapore, we are like straddling on every single means of prevention. So we'll have a little bit of this, a little bit of that, but each one has its own strategy. So our current stand is there will be preferential distribution of that drug. And it will be like a ring vaccination process, ring distribution process, sorry.
Dr. Quek, I have a question about the thermal scanners. Right after SARS, I was involved in some groups trying to figure out, what are we going to do? And we could never really find any hard data that the thermal scanners were really useful, that they actually... Do you have comments on that?
You see, a lot of things we did during SARS were actually to reassure the public and reassure our own nurses. And the reason why, it was not just in our hospital, even our airports had the thermal scanners.
Right. I remember coming off the plane.
Correct. And you'll be zapped. And all these measures were taken to sort of like reassure the public. But actually there's no scientific data. But it did do a very general screen. It did sort of like help us pick out the ones that were highlighted on the scanners and go for proper checks. And if the second temperature reading is normal, they are free to go. So it was both things. We were trying out new technology. We were reassuring the public. We were reassuring the world that Singapore is safe to come in. So a lot of things we did, like the masks, whether is it useful? Did the PPE stop the SARS transmission? Nobody can tell. But it helped our workers to come back. It helped the family to be happy that their children who is working in a hospital are being taken care of. So it was more of a psychological effect than a scientific. So that was what we found out during that period. Yes.
Other questions? All right. Dr. Quek, thank you very much.
Thank you.